In our ontogenetic growth and development, if you see, our kids, newborn babies, start their growth and development from class 2 skeletal relation. Originally class 2. About half of our population established class 1. But as I explained before, nearly half of population stay class 2. Yeah. So about 10% jump to class 3. Now you understand this part. Now here, why class 2? They were not becoming class 2. They failed to become class 1 for some reason. This is you must understand why class 2. Class 3, no, therefore, let's show you this. I explained from this morning and class 1 normal growing case slowly increase molar partial dimension and the mandible rotate forward. We have started class 2 with skeletal. Slowly mandible adapt forward position. Then establish class 1 skeletal and class 1 groove. If you look at the class 2, this is also growth sample, longitudinal sample, so big difference from class 1. You see here, vertical dimension or occlusal plane, not like class 1. No increment of vertical dimension. Okay? Therefore, the mandible cannot adapt by rotation and forward adaptation. Impossible. Rather, this kind of a steep occlusal plane, the mandible rotates back. Then the mandibular plane angle is slowly opening. This is the class 2 case. I showed this class 3 case, and maybe you understand. Okay, the occlusal plane again, basically the vertical dimension increase, that means the maxillary complex go down. And the occlusal plane change like this, molar is more increased dental height. If this happens, vertical dimension increase, then mandible rotate forward, then adapt nicely. But something too much increased vertical dimension, too much flattening occlusal plane, then some case rotate backward. This makes anterior open. But class 2 case, started the class 2 skeletal, but stay here, class 2. Okay. Bishara published one paper in 1988. He checked completion subject, 242 sites, and then he checked the milk dentition days plus 61%. That means this is he said terminal plane is vertical type. This is a majority. Right? But this brush type or vertical type terminal plane in milk dentition, this growing teeth, finally 56% plus 1 occlusion established, but 44% still after completion of the permanent dentition. Plus 2. Pretty many. Yeah? And this is a real old paper. We are published this paper long time ago. This milk dentition stage, majority show terminal plane vertical type. Okay? This group, initial occlusion, that means first molar erupting, initial occlusion cusp to cusp, 77% cusp to cusp. That means half plus 2 group. Right? And this group, well, 70% finally go to plus 1, but the 30% finally plus 2. If distal step type of terminal plane, 100% plus 2, this group, final occlusion also 100% plus 2. Therefore, many growing kids show the plus 2 occlusion. Long time ago, we have leeway space hypothesis. Everybody knows this. Nance proposed this idea 1947. We have, if you compare the buccal segment, milk teeth measure distal distance, size of the tooth. Permanent teeth are smaller than milk teeth. Therefore, his idea is how to establish plus 1 after exchange buccal segment, more leeway space in lower. Therefore, after exchange, upper and lower molar migrating a little bit forward position, but lower is big amount of leeway space, therefore more forward. Then establish plus 1 group. Is this true? Therefore, many pedodontists and orthodontists, if they see 7, 8 years old, then plus 2, half plus 2, they say, wait, maybe naturally grow, then would finally establish plus 1 occlusion. No. In my practice, 50 years, I observed such a patient, young patient. I never see this kind of establishing plus 1 occlusion. If you see 7, for example, 7 years old, oh, this kid is class 2, half class 2. Then 8 years, 9 years old, 10 years old, if I follow, no change, always plus 2. Therefore, okay, if you see 5 years old, 6 years old, you see the first molar start eruption. At that time, still have plus 2. Many people say, wait, but you should, I like to recommend, you should immediately concern. This is early treatment. Why wait? Okay, for example, in my department, we have growth samples. I check simply, for example, this is initial occlusion, that means 6 years old. Then I check my department for the material, check molar relation, dental relation. Plus 2, plus 1, plus 3 here. At 6 years of age, 52%, pretty many kids show up. Plus 1 occlusion after first molar error. Now, but another half, nearly half, 46% of kids show 10 plus 2. Okay, then I follow this rule. After that, what happened? This is age something like 8, 9, that type of age. Just before exchanging start the buccal ceremony. 6 years of age and now 8, 9 years old. Very small percentage, only 4% from here, established class 1. But another case, at this stage, before exchange the buccal segment, nearly 40% still class 2. After exchanging, even if we have a B-based phase, but no change, 100% here, last here, also class 2. No change, no chance to establish class 1. Okay. Then, this is the occlusion development, the normally growing surface. Now, you should see what happened in occlusion. Yeah? Initial occlusion, many kids showed half class 2. Yeah? This is 6 years of age. But 7 years old, this side is more already class 1. Looks class 1. But this side, half class 2. 8 years, 9 years. Okay. Interestingly, very, very interestingly, 7 years old, this side class 1 molar occlusion established at that time. See this midline. Originally, midline coincided, but 7 years ago, mandibule shifted well to the left. Okay? This is not tooth movement. Mandibule shifted. Therefore, this side plus 1. Here, put after. So, after that, slowly, this midline changing. At 9 years old, almost coincide. At that time, here, half class 2, but now very close to class 1, more class 1 type. This kind of mandibular position change. This is very, very important to establish nice occlusion and mandibular growth. Okay? Now, this kind of change very much depends on vertical dimension change or occlusal plane flattening. You should follow the patient how much increase vertical dimension, change occlusal plane. Okay, anyway, but I want to say, explain this. Now, 9 years old, okay, both molar relations, looks class 1. Oh, very happy. It's okay. Let's big compile. You know compile? What is it? Salute? Salute? Nero. Yeah. Okay. But unfortunately, this kind of looks class 1 molar relation, but this is not perfect. Because 9 years old, now premolar eruption, perfect premolar. But the premolar relation is still half class 2. Yeah, and this side still upper premolar still not erupted, but this kind of relation is half class 2. Okay, 10 years old, this midline coincides perfectly. They slowly establish the class 1, but still canine is not perfect class 1. And if you see 11 years old, 12 years old, now here midline okay, both sides class 1, premolar okay, canine also class 1. Yeah, this stage, 9, 10, 11, 12 years old, this stage is very, very important to develop or establish class 1 occlusion. Because I like to show you 9, 10, 11, 12, like this. See, molar, very close to class 1. But premolar eruption and a half class 2. But the next step, premolar change this relation. Okay? Why? Why it happened? This makes more nice class 1 molar relation. And this 11 years old, nearly perfect class 1 interdigitation. Once again, this is not a tooth movement. mandibular adaptation for continuously molar vertical dimension increase and molar eruption. If this vertical dimension increase, bite is a little bit slightly open tendency, but 10 times mandible adapt more forward. Then this should here, premolar. Molar have a task, very important task. The guided mandible more forward. Therefore, this is we call this premolar guided mandible. We call retrorusive guide, and finally mandible adapt more forward position and establish perfect plus one occlusion even after second molar erupt. Very, very stable plus one occlusion. This is okay. About 9, 10 years old, upper and lower tooth number 4 erupt. That means the upper, lingual cusp, tooth number 4 down. And this lingual cusp meet lower 5, the initial contact. Lower tooth number 5, he has a very nice, the central part, this beach. Yeah. Okay. Then this lingual cusp contact should be a little bit distal surface of this ridge contact. This lingual cusp final destination is distal fossa. Yeah. Right? Therefore, initial contact here, the mandible go forward, and finally, this lingual cusp and the lower distal fossa coincide, establish very stable class 1 occlusion. This is a really, very important step of the occlusion development. This is one of the big reasons for me. I don't like to remove premolar. If you remove premolar, it's very, very difficult to establish nice occlusion plus one occlusion. If unfortunately upper lingual cusp contact with the nasal side of the surface, then guided mandible backward this way, so finally go to 3 plus 2 occlusion. So this is reproducible guidance. Very close. The initial contact, upper and lower past molar contact here. See, this nice shape of the this premolars contact here, then guided like this. Initial contact here, then guided forward, the mandible adapt forward, and finally, plus one occlusion established. Okay, this is, don't forget, this is introducive guidance, vertical growth. I think the most important step to adapt the mandible forward. increase vertical dimension, change of cruiser plane, and also remora guided mandible forward. So, let me show you this class 2 development. Half class 2 initial inclusion, till half class 2, up to 9 years old, both sides, half class 2. But now, this is the case. Class 2 development, usually, as I said before, no increment of vertical dimension and almost no change of crucial plane. So that the mandible very difficult to adapt to forward position. And finally, 10 years old, 10, 11, 12 years old, I have to show you this way. Now this is a 10, 11, up to 14 years old. See, 10 years old, this side is very close to so this side, to tendency, but now, premolar eruption, unfortunately, this kind of relation, no chance, the lingual cusp contact with lower reach, which is number 4, reach, distal side. Therefore, start guided mandible backward. Right? Then finally, both sides of occlusion full plus 2. Yeah? Therefore, we have to control. If we want to do some early preventive orthodontic treatment, early stage, 6, 7 years old, you should make a diagnosis, treatment plan, then change, right, to mandibular adaptation. What? This is a really, really necessary because this kind of case, in the future, 10, 11 years old, start joint problem. It is sure. I will show you data, but this is a really big problem. Mandible adapt forward. Well, 25 years old, 1996, we published a very important paper. The steep canto posterior occlusal plane was strongly correlated with small detruded mandible with a backward rotation of the mandible and a short vertical height of upper molar. Then in this paper, we recommended in class 2 treatment, we have to control this posterior occlusal plane and the vertical dimension. This is very important. But I don't know. We published this paper in European Journal of Orthodontics, but no response. After this publication, we continuously published the paper about this posterior occlusal plane problem. But I don't know. Orthodontics is lazy in the world. They don't care about vertical dimension. Okay, this is data. At that time, we compare normal, that means the class 1 subject and the class 2 subject. Only, difference is posterior occlusal plane. In class 2 case, very steep posterior occlusal plane. Therefore, pogonium position, anteroposterior position, is very much backward position. That means class 2. Okay? Another paper we published, we compare class 1, 2, 3. The only posterior occlusal plane, different age, around 6 years of age, and before exchange buccal segment, after exchange, and the final occlusion. See, class 2 people, more and more. At 6 years of age, we have no significant difference among different malnutrition groups. But slowly, class 2 people make more and more steep posterior occlusal plane, and the class 3 improve class occlusal plane. Therefore, total vertical dimension increase, and point to be that is a mandible adapt forward position. This is a very nicely correlated vertical dimension and the mandible adaptation forward. Okay? So, establish the class 1 occlusion or skeletal. This is a really important subject. When should we be concerned about this? Also, don't miss, everybody has a responsibility to take care of the growing teeth. Okay? Therefore, let's talk about the mandibular position and its maintaining mechanism. Let me speak about this kind of primate craniofacial morphology. I say this kind of primate group has no variation. They are rather same type of the face. Okay? Human, we have a wide variation of primate. No. Why they are very stable mandibular position? Mandible always same and occlusion, perfect class 1 occlusion, but see here, they have a very big canine. Then this canine interpretation into class 3. This is very, very important class. Canine, I want to say canine stop. We keep mandible this position. Canine rather class 3, that means a mandible always rather forward position. Right? And if you look at here, joint, condyle, this is see here, behind of the condyle. This is a bone, bony. This is the anatomical word, the littoral. I forgot the littoral post-glenoid spine or something, what's in this kind of work. Here, very nice bony support behind the condyle. Condyle supported by this bony structure, therefore, no chance that condyle displays backward. Oh, very strong structure here. And also, I want to say, interdigitation of the upper and lower teeth. They have a very nice cuff inclination, very strong, nice morphology, then interdigitate all the teeth into class 1. And also, the vertical dimension is good enough to keep mandible, and the occlusal plane is very much flat. All these supported the mandibular position. Therefore, no variation. Always almost the same type of face. But unfortunately, this evolutionary process we lost very important number 1 and number 2. We have, in human, we have no this kind of interdigitation. And we lost this bony support behind the condyle. Right? Only vertical dimension and occlusal plane try to keep mandibular position. But as I explained before, this occlusal plane and the vertical dimension during the growth and development are changing. This is a danger. Changing. We must observe carefully our teeth. This is mandibular adaptation is okay, or some problem. Yeah, anyway, this whole element, canine stop, post-glenoid bony support, and the tooth morphology, and vertical dimension, and the occlusal plane, this whole element, very, very important element to keep mandibular position. But we lost here, this one. Well, but tooth morphology, think about it. Tooth morphology, if you compare the primate and the human tooth morphology, this is pretty okay. Yeah? This is a human tooth structure, nice cusps and the fossa. If you compare primate and the human tooth morphology, we are maintaining nicely tooth morphology. Therefore, tooth morphology, no problem. But one problem, okay, in human growth and development, see, this is I try to compare human milk dentition and the primate, orang or gibbon, gorilla milk dentition. Oh, nice. Already milk dentition is, look here, canine, class 3, thick mandible forward, right? And this tooth milk teeth interdigitate nicely, then distal surface of milk molar already major step type. That means class 1. Well, they are primate they are quickly grow. 2-3 years, then almost adult type of craniofacial complex. But human, we have, as I said before, 60-70% of terminal brain of human baby are milk dentition teeth. Vertical, that means a half class 2. Therefore, initial occlusion after tooth number 6 is up. Many kids show half class 2. This is a big problem in humans. You have to take care. You have a responsibility. So, then human, and this is very hard work for growing kids. They must adapt mandible forward position. They was born as a class 2 skeleton. Then milk dentition stage, 3-4 years, class 2 occlusion. After first premolar eruption, many kids showed half class 2. When they have a chance to change, we have to think about it. That in Japanese, periodontist or orthodontist say, no, this is no problem, we should observe. As I say, my data, if 7 years old growing kid still half class 2, almost nearly 100% of the final occlusion also class 2. That means we have to change early stage. Early stage means early mixed dentition stage. 6-7 years of age. We have to concern. They have to change. This way, mandible adapt forward. This is more, start this past 6 years more start eruption, then change mandibular position, then make major step type of terminal plane. Then after 6 years more enough, establish class 1 occlusion. This is ideal growth. The lower biggest cusp, lower 6 distal buccal cusp have to contact upper 6 years molar, here transversal ridge. The nasal surface of the transversal ridge and the lower cusp contact. Then mandible adapt forward position. This is a very, very important stage for the class 1 establishment. Like this. Okay? Lower distal buccal cusp contact is upper. This is a transversal ridge. The major surface of this transversal ribs, contact. This is the real class 1 illusion. And another problem in Homo sapiens sapiens, this is very, very important, especially for orthodontists. Okay? Another problem we call closed arch function. What is the closed arch function? If you compare the primate and our dentition, upper arch, okay? The primate, for example, gorilla, so something like this. This is the dental arch, and the upper front teeth very much flaring out this way. Therefore, there the mandible functioning to the upper arch. Right? And if mandible wants to go forward, no problem. Here, flaring out. Therefore, as far as the forward movement or laterally move, this is no problem in primate dentition. But our dentition, what do you think? Well, canine integrated into this arch. Then mandible have to work inside of this arch. Right? This is a very, very hard work. Now, if mandible want to go forward, not like we have this here, something wall, or we call this fence. Yeah? Here. Therefore, mandible have to move once open and walk over. But going back, once open or forward movement, finally closing position always is inside of the fence. Therefore, our neuromuscular system try to pulling mandible back and go to final destination inside of the upper arch. This is we call closed arch function. Sometimes we call this fencing. Okay? Now, fencing, but if upper arch flaring out, this is let us say that the modern society, they don't like too much flaring out. Therefore, orthodontists try to retract the upper front. Many times. This makes problem. We have to be very, very careful. Anyway, the human dentition, we have a closed arch. A closed arch function. Therefore, if mandible works, whatever chewing or speaking, this kind of function, dynamic movement, we need space here. Space. Don't close this space. We call this intercoronary opening angle or sometimes space, interconal opening space. If mandible dynamic way is functioning, the condyle nicely functioning this way. But if you narrow this space, now this is a big problem. All the system try to bring mandible backward. Therefore, condyle movement, opening, closing, go back, more back, then go back. Here. This kind of movement. Then slowly joint as a problem. Create big problem. Therefore, once again, I want to go back. Yeah. We shouldn't narrowing this space. Only dentist narrowing this space. Okay. Intercoronal opening angle or space. Here, this is a very, very important space functioning, provide this functional freedom for mandibular function. This is very, very important. Okay. So, let's talk about we have this four element to keep mandibular position, but we lost this two, first and second. This one is okay, but vertical dimension of gluteal plane, this is changeable, especially growth and development. Started from class 2, slowly increase vertical dimension, change posterior crucial plane. Therefore, we have to be very, very careful. Carefully observe if something happening immediately, we have to confirm this. Okay. But, okay. Always, I saw this. During the growth and development, always mandible go forward. This is basically vertical growth and occlusal plane, flattening. This kind of change or growth and development, this is very, very important, especially for establishing, of course, class 1 occlusion, but occlusion support. Well, all the nasology started in California long time ago, 100 years ago. Maccaran started California Nasological Society. Then they are approaching to the measuring this mandibular functional movement, establish nice occlusion, but all the time, they did a big mistake. Their goal of their occlusion treatment, final goal is mandible push back, right? Therefore, all the nasology, big name, Peter Thomas, try to make occlusion, they make a class 2 occlusion. No, this is something wrong. Okay, don't push mandible backward. This was the piece of the nasology error. Yeah. Then, okay, what is the occlusion support? They are becoming finally canine guidance and so-called organic occlusion. This is a very nice idea, organic occlusion. In other words, organic occlusion, mutually protected occlusion. All of you are dentists, you know already this is a mutually protected occlusion. And when you bite strongly, the posterior teeth protect anterior teeth to not grow. Anterior teeth protect molar by nice guidance system. This is we call the mutually protected system. But during the growth and development, establish molar if strongly biting, like wrenching. Breakthrough is now very, very important function of the masticatory organ. Therefore, such a severe overloading situation, posterior support, crucial support is very, very important. If you see this kind of class 1 skull, class 1 occlusion, crucial plane pretty flat, the average position of the occlusal plane is, go through the side point here. Then if you bite strongly, but during the growth and development, we started a very steep occlusal plane, right? Slowly, this occlusal plane changed. I saw already. Then slowly flattening occlusal plane, the mantle rotate forward, then becoming class 1 upper and lower jaw relation. This kind of growth and development always mandible rotate forward. That means, think about joint. Always condyle pulling down. Right? This is very important. Pulling down. There are many basic research people prove condyle can grow if unloaded situation. Condyle can grow. Especially Hong Kong University people, Professor Hart and Ravi, this group showed very nice basic research, and also Weber showed the unloading joint make condyle grow. Compression of the condyle cannot grow condyle. Therefore, mandibular forward rotation and condyle bring down, always unloading the joint. This is very, very important. This kind of situation, if he bites strongly, you can see here. We have a space between condyle and cranium. This is an unloading situation or occlusion support. This is occlusion support. Yeah. But now, problem. If you see class 2 kids, their posterior occlusal plane is very thin, not enough vertical dimension. This kind of a growing subject, if she bites strongly, but we have no space between online and brain, that means always compress the joint. We can measure how much compress in our diagnostic system. Okay? Therefore, I can say, whatever the class 2 patient, we have to make unloading joint. Unloading is the condyle pulling down. This is a very, very important approach to the class 2, especially high angle case. This means, mandible rotate, tilt backward. This makes us very strong compression here. Therefore, you can see here already condyle flattening and no space. This is, I want to say, overloading the joint. This is a big problem in class 2 skeletal group. See, already condyle flattening, no space. This is class 1. Okay. But, so, this is a very, very important growth and development. Increase vertical dimension, area of occlusal reference, then make occlusal support. This protect the joint. But how about this post-glenoid bony support? We lost here. This one. But we have, we have good news. Good news. We developed new systems during the evolutionary process. We call this craniomandibular system. What is the craniomandibular system? You don't know. And this is Slavchek's idea. Okay. He did many research about the craniomandibular system. In my practice, I always, if you go to the outside of the room, we have one poster showing condylography. As I said before, in my department, 1987, we incorporated the axiograph. All the orthodontic patients which took axiograph to make a nice diagnosis, but especially if mandibular position is okay or some pathological problem, this is very, very important subject or step to do diagnosis and treatment plan. Nowadays, without this kind of examination of the joint, I cannot read the patient. But anyway, what is the craniomandibular system? This morning, I say, 25 years ago, when I started in Vienna, the orthodontic course 3 years ago, I put name this course, Craniomandibular orthodontics. I said, what is a craniomandibular orthodontics? Now, if you understand craniomandibular system, that's why I say craniomandibular orthodontics. Maybe you can understand. Let's talk about the craniomandibular system. This is a system because if you think about the TMJ, many people talk about the temporomandibular joint. Temporomandibular joint is just a joint. Everybody talk about the condyle, disc displacement, only here. Huh? But this is wrong. We developed new system to keep mandible. This we call craniomandibular system. What is craniomandibular system? Cranio CMS. But if you don't like craniomandibular system, just say TM joint. But always, if we discuss about the temporomandibular joint, our concept should be craniomandibular system. Craniomandibular system consists of this kind of a bone, cartilage, ligament, connective tissues, synovial apparatus, articular disc, and the muscles of craniomandibular system. All these are working for keep mandibular position. Therefore, this is very, very important. Mandible is a hanging from cranial bone. Usually, this ligamentous system hanging. Therefore, we have central self-centering mechanism. If you don't have any muscle system, just mandible is a neutral position. But if we have many muscle, upper and lower teeth are biting, contact, this makes displacement. This is a very important diagnostic system approach. Okay, this is a temporomandibular joint. Yeah. Fossa, disc, condyle. But this is the only here you are talking about joint. Craniomandibular system, for example, the behind of the condyle, we have a very nice system. This is a bilaminar zone or littoral-articular connective tissue. This is a kind of center stage. This is a littoral pillow. If condyle move forward, then over, this pillow protect the forward position, not too much backward. Right? So this pillow has two important roles. We call hydrodynamic protective mechanism. Another one, hydrodynamic position mechanism. If mandible going back, as I said before, this hero protect, don't go back too much. The supply, the blood supply here into connective tissue. This is worked very nicely. But another, this position mechanism, maybe later I will show you the case. Especially, all that go forward. Well, we are speaking animal, right? All day speaking, especially lady. But usually, if you speak whole day, but don't get tired of this masseter muscle or temporal muscle, whatever muscle system. Normally, don't get that tired. But some patients, I have a very severe case. This is a male patient. Every morning, school teacher. Maybe after, maybe this case will come. Anyway, school teacher, nearly 30 years old, teacher, they go to school, middle school teacher, in the morning, start talking in front of the many students, but 30 minutes speaking, suddenly start get tired. This muscle system, all muscle system. For this reason, he quit this job. Why? Why this happened? Speaking, always mandible move forward, right? How many millimeters go forward? I measured and published one paper. Usually, normally, maximum 3 millimeters, maximum. Then speak. How much open the mandible during speaking? How much rotate mandible during speaking? Louder, please. 7 to 10 millimeters. So come forward, then speak. Opening 10 to 7 to 10 degree. Okay. That means 7 to 10 degree opening the mouth. It means many this this part of the muscle system right open. This is too much. I published the paper only 3. Within 3 degree. 3 degree open too much. Because lot of the work of the muscle system. I started speaking this morning already. Now, now close to 5 o'clock. But normally I don't get tired of my muscle system. Okay, therefore, during the speaking, this condyle maximum 3 millimeter forward. Then, during the speaking, only 3 degrees open, close, this kind of movement. That means no get tired. But some patients easily get tired. This is a problem. Okay, this kind of you know, 3 millimeter, for example, go forward. Then blood supply here, disconnect tissue, and stop and keep this position. Keep this position by connected tissue, blood supply. Therefore, this forward position, we are usually we are not use muscle system. Just here, keep. Only 3 degree open. But this is also not so much use the muscle system. The joint is usually very smooth movement. Therefore, muscle system very safe. This is the retroarticular connective tissue and working like this. But some cases, patients have a distal problem. I will show you this case. Okay. And of course, this ligamental system here, very strong ligament, this lateral ligament. Keep contact, not a forward. Okay? So, and inside of the joint, if you see, this is we call temporal discocondylar ligament. From temporal bone goes through the disc and this very strong fiber, collagenous fiber, attached to the behind of the condyle. This also keeps condyle forward position. Ligament is not like a muscle system. Ligament is ligament. Very strong fiber. Keep condyle forward position. Yeah, sometimes this kind of condyle, why? This condyle shape like this. Condyle usually like this, but if mandible go back, this fiber, this ligament, keep the condyle position, therefore strongly this ligament push some compression forces, therefore change condyle morphology like this. Yeah. All this system keep condyle or mandibular position rather forward position. This is a new system developing during the evolutionary process. But of course, most important element is the now muscle system. We have lateral pterygoid muscle. Yeah? Lateral pterygoid muscle, we can divide it into two parts, superior one and inferior one. Okay? Inferior part of the lateral pterygoid muscle, this is an opening muscle. Right? If you want to open this muscle, pulling condyle forward. But how about superior one? No? Huh? No, no, no. No, no, lateral movement, pulling. This one, inferior one, pulling forward. Outer, please. No, no. Why lateral? Superior one is, this is closing muscle. Okay? This is an opening muscle, but this is a closing muscle. When you bite or curling, then this part of the muscle very active. Let me show you this. Okay, this muscle. Okay, this is if we approach from superiorly, this is a temporomandibular joint. Okay, then this is a articular disc. So we are seeing from superior. Okay, therefore, behind of this is a articular disc. Behind of this, here we have a condyle. Then this is the lateral table muscle, superior head. And not only this, but also temporal muscle, anterior part of the muscle, temporal muscle, some fiber, muscle fiber into the joint. Then attach the disc and the condyle. This is a masseter muscle, some fiber coming. Also, this is attached to the disc. Okay? All these three muscles are closing muscle. Why do we need closing muscle here? Very interesting, right? Okay? Think about it. This is schematically drawing anyway, lateral pterygoid muscle, temporal muscle, anterior part, and masseter muscle. Okay, then if we bite or grinding teeth, anyway, closing situation, closing situation is very, very dangerous. Easily mandible go back. But this muscle system always pulling the condyle and the disc forward this way. Mandibular position, including this muscle system, this is a system, cranio-mandibular system, not a simple joint. Please understand this. Superior head is closing muscle. One very important, I think, very important paper published. Okay. And this is in Japanese guide, Iraba, and this group published this paper in Journal of Neurophysiology, 2000, published this paper. See? Okay. They put EMG needle electrode, put carefully here. This is a superior head, this is a inferior head, needle electrode, then measure separately. A is upper, the superior head. B is lower and inferior. Then B, this is a chewing movement. This is opening station. First, here, pulling condyle forward. But the closing now, closing situation. Now, upper superior head active. Closing, opening, close, opening. This kind of completely different function of this muscle system. Please keep in mind, superior head is closing muscle. Then is a very interesting approach. If we push mandible backward, this way, push. What happens? Here, the muscle system. Very strongly. Superior head is very much active. That means pulling condyle and the disc forward. Okay, data like this. Okay. Push mandible backward, then superior head and inferior head. No activity. Only superior head of the lateral table muscle very much active. Means if displaced mandible backward, immediately this muscle system pulling keep mandible forward position. This is a very, very important muscle. We call this muscle, this lateral table, superior head, temporal muscle, masseter muscle. We call this muscles of craniomandibular system. In this function patient, this is a very, very important. Okay. So, this is a French guy, long time ago, published this paper, the immediate side shift, experimentally, he did very interesting on the linear surface of the canine, put some material, okay, this kind of acrylic coverage here to make a strong canine, let's say, canine guidance. Then measure the condyle movement. If we put here or increase canine guidance, inclination, or narrowing intercoronal opening space in canine, if you do this, see this red color, always condyle move, this kind of shift and move like this. We call this immediate side shift. All the massology group say, oh, this kind of immediate side shift, this is a normal movement. No. This is a pathological movement. This is indicating something, mandibular displacement. Okay? If you see this kind of movement, immediately, oh, this patient, his mandible is displaced this way or that way. you have to make a diagnosis and correct mandibular position. Okay. Yeah, that case, if you put here, for example, canine guidance to speak, this immediately, this muscle system, craniomandibular system, reacts. The mandible go back, but not only go back, but also laterally shift of the condition. Therefore, start this kind of immediate side shift type of the movement. Well, content graph showing very nicely, we can make a diagnosis through immediate side shift. This is a pathological movement now. If original condyle position here, but if this condyle shifted to the little bit right side, then now this is a pathological position. The start movement from pathological position, very early part, this kind of shift. Then start normal movement. Therefore, immediate or early side shift is something like indicating pathological mandibular position. Keep in mind. Okay. Yeah. And Macaulay's long time ago, Macaulay's is a nephrologist in the United States. He was practicing in Nashville or Tennessee or some area. He's a famous nephrologist, but he did very nice research. He did two previous paper. He put canine legal surface, but Macaulay's did anterior here, something narrowing this space or increase this guidance integration. Then he 30 volunteer to use the healthy volunteer, but to put front piece, lingual surface, a little bit material and narrowing the space. Okay? The result he showed very nicely. Within 3 days, 80% of volunteers start creaking joint. That means mandible going back. And his conclusion of this paper was 15 or greater this anterior guidance is too steep. This makes joint growing. But after starting creaking joint, immediately he removed this one. But after removing, go back to the normal space. That means that type of the narrowing intercoronal opening space makes mandible go back. This is a big problem. Okay? Therefore, I'd like to finalize this part. Now, craniomandibular system is a system which Honda position the forward position. Lateral pterygoid muscle, superior head, temporal muscle, anterior part, going here, and also masseter muscle too. Then here, this is all these closing muscles, free. Honda is forward position. During the growth and development, mandible always adapting forward position. Right? Also, after complete permanent dentition, still this system keeps mandible forward position. Yeah? Therefore, working this way. The mandible is maintained in superior forward position. Therefore, our occlusion treatment also we have to establish very nicely harmonized with the craniomandibular system. That means occlusion-wise, we should bring mandible forward. I already explained the truthful guidance. And over. Don't push mandible back. Premolar extraction is the worst. Molar extraction anterior is over lazy. Therefore, I take this premolar extraction orthodontic treatment. Okay, I'd like to finish this. During the growth and development, and always mandible going forward. The mandible always adapt forward position. Okay, the mandible adapt this way, then always condyle can grow the secondary growth of the condyle. This is our system in our occlusion treatment. Don't against craniomandibular system. Okay, I like to finalize today's my talk. Tomorrow morning, I like to continue the subject class 2 more. Now, if you have a question, please.
Vâng, xin chúng ta đến phần câu hỏi. Chúng ta có câu hỏi được. Hồi nãy có rất nhiều bác sĩ muốn hỏi đấy, nhưng mà bây giờ rất là okay. One question.
Như anh Hồng như vậy, bản thân họ trong cái điều trị thuộc cả tháng thái thì mắt khoảng nhái bị dốc thì mình sẽ điều trị bằng cách là làm khoảng mắt khoảng nhái từ sau.
Okay.
Thì
final question.
Yeah, I will translate into Vietnamese after he speaks the Vietnamese.
Yes.
Yeah, after I will translate for you, Professor. Thank you.
Thì khi đó thì cái trường hợp điều trị vì đã từ trước. Còn khi điều trị khớp cắn tháng 3 thì có phải lúc nào khi mình mắt phẳng nhái nó cũng phẳng và mình sẽ làm dốc nó sẽ bị trường hợp dưới sau hay không? Còn một câu hỏi nữa là trong những một số cá hàng bá thì em thấy ở mặt phẳng nhái ở phía sau và trường hợp nó rất là dốc.
Too long.
Trường hợp đó mình có làm dốc ngựa không hay là thử thế nào?
He has two questions. Question number one.
Okay.
Yeah. In the class 2 treatment, and most of the class 2 case, the posterior occlusal gland is stiff, and our treatment is to make the occlusal gland flatter.
Okay,
To bring
this
the
question
mandible.
should be tomorrow.
Dạ, câu hỏi đó ngày mai, tức là
second
về
question.
hạng 2. And the question is that in class 3, we need to make the occlusal gland stiffer if that's right.
Yes.
Và đúng là như vậy, hạng 2, hạng 3 là phải làm cho. Here of that class, we notice that some of the class 3 case, the occlusal gland, the posterior occlusal gland is hit already. And in the treatment plan, do we need to make it stiffer? Is that the way we treat the class 3 for the stiff occlusal gland in class 3 already?
Yes, sometimes we have such a case, but always, therefore, I explain not only occlusal plane, but also vertical dimensions increase. Okay? Sometimes upper vertical dimension not so much increase, but the lower increase so much. This is also same reaction of the mandible. Therefore, in your diagnosis, even high angle class 3 case, open bite case, this case, deep occlusal plane, therefore, you must control lower occlusal plane more than upper. This kind of approach necessary. Okay? Then, class 2 case, posterior occlusal plane speed, this is usually very steep. Then, now, as you say, we have to flattening posterior occlusal plane in class 2 treatment. But this is, I will explain tomorrow. Yeah.
Mọc răng thì lúc nào răng hàm trên ấy, nó cũng mọc dài hơn răng hàm dưới, tốc độ nhanh hơn. Một năm nó mọc xuống dưới là 3 ly, 0,7 ly, nhưng mà ra trước là 0,3 ly. Nhưng mà cái hàm dưới là tuy nó mọc quỹ là bên trên là 0,5 ly một năm, nhưng mà ra trước là 0,5 ly.
Now this is a class 3.
Yeah, class 3. Yeah. He said, okay, the class 3 is already steep because in cases like this, and his question was, can
No, I don't think so.
It's true, it's just everything can happen here.
You are talking about high angle class 3.
Yeah, but this is steep already. And he said,
sometimes we can see
steep. Yeah. Okay. And he asked, his question was, can I make it even steeper?
No. Therefore, I explain such a case. Lower occlusal plane should go down, flatten.
So, if you stick too much,
người ta
I will give you
bỏ
the
cái kéo
answer.
cao
Help. If you stick too much, now you cause interference.
đấy,
So there's a limit for
cervical cái kia ấy,
inclination of the plane. He explained
em biết rồi, nhưng hai cervical có cái khinh đeo ấy, đánh phải giảm góc 30 độ,
so the mandible can start
giảm góc nghiêng.
stick too much, you compress the joint. So you cause a lot of interference in the posterior area. There's a limit, and you need to know the SCI.
This is a little bit more advanced
trôn
answer.
tí thôi.
Yeah, and just say
Chứ không phải là
steep
đi
or not
xa nhé.
steep, or
Nó bản chất đi
steep
xa
more,
là
not
nó
steep
phải kéo
more.
cao nhiều khi là nó
So
xa
if you
nó
don't know
mới
the SCI, you don't know
sai
how
cơ
to
chế.
make it even more steep.
Okay, at the moment, I try to explain simply because, of course, actually, patient by patient, we have different problems you have to think
Ở
about.
Mỹ là kéo cao
What
nhưng mà sai cơ chế
What is
theo
behind the
cái
question?
nhưng mà lại sai về
This is what is behind. So how much I can go. So it really depends on the joint.
The final goal of lunar brain, we have to think about. Final goal. Tomorrow. Another question?
Em chỉ có hai câu hỏi. Thì em muốn hỏi câu nhất là cái thầy có thể nói rõ hơn em về cái mặt phổi nhai làm sao mà với cái trường hợp mà mặt phổi nhai nó phản ánh cái năng lượng phía sau để không thể chúng rõ hơn vấn đề đấy. Với cái câu hỏi thứ hai buổi sáng là với cắn hở khi mà tăng chiều cao mặt phía sau thì làm cho hàm dưới nó xoay mở, và khi mà cái hàm dưới nó không xoay đóng được ấy thì nó dẫn đến hiện tượng là cắn hở. Thầy có thể giải thích thêm về vì sao nó lại thất bại trong cái việc xoay đóng ạ? Em cảm ơn.
He had the two questions. Can you, the number one, can you explain again? When the occlusal gland is flat, we have a good occlusal support. The good occlusal support when we have the flat occlusal gland. Why? Why when we have the flat occlusal gland, we have the good occlusal support and the mandible adapt forward? Can you explain again that? Professor Nelson, you got my his question. Yeah. Lần trước thầy cho thầy cái microphone để thầy ông hiểu các học trò. Tôi nói vậy đó mà thầy Sato hơi để thầy chân tình lắm. Thầy giúp cho tôi hiện tại cái câu hỏi đó. Ai hỏi câu hỏi đó em thầy
I didn't see.
Đây,
All facing backward.
dạ.
Who asked the question?
Đó em thầy này giao tay cho thầy thấy.
Oh, thank you. There's a confusion here.
Có một sự nhầm lẫn ở đây.
Inclination of occlusal plane and support is totally different. It's different thing. Support of the joint. Of course, we have to be careful with the vertical control. I can have a support and not super flat occlusal plane, so it's a mixing of questions. Depending how the upper molar and the uprighting of the lower can give support. Just case by case again. Super difficult to give an answer like that. You correct me, Professor, if I'm understanding.
Okay, I like to change my schedule tomorrow. So many people are very much interested in more function and joint program, therefore. Anyway, tomorrow we'll discuss again. This is a very important question. What is the support? Okay, let's go.
Now the second question. The second question. When we have the adaptation forward and some of the open part, you say that the mandible will adapt backward when forward and when backward. in the changing of the blend, the mandibles sometimes adapt forward and blow the fight, and sometimes it's adapt backward and causing the open fight. This is the confusing. If there is one slide, there are two arrows. One is adaptation forward and can be adaptation backward of the mandible. He has the confusion about it. Dr. Nelson, do you understand?
Yeah.
You can professor. Plans to the professor his concern.
Anyway, the mandibular adaptation is always the adapt to the low vertical dimension side. Okay. If posterior part is not enough vertical dimension, that means a low vertical dimension, always mandible adapt backward. Okay? If too much increase here, therefore low vertical dimension is the anterior part, therefore mandible rotate adapt forward position. I plan to explain tomorrow so-called the mandibular lateral shifting case. This is also a big problem. Always mandible shift or adapt low vertical dimension side. This is kind of reason. Therefore, not enough. Please.
I would just add, this is already explained, but to complete, sometimes you can rotate the mandible by flattening the occlusal plane, but be careful to not hit the anterior piece. Every time you touch the A9 or incisors in this much rotation, the mandible will also get that. Not only because the occlusal plane is steep or inclined, but also because anterior epiphysis, as you see the paper from the ball, paper from the other altar, name it. This is also caused because of superinclination, positively or negatively, on the occlusal plane. So you need to forget. You cannot forget that incisors in canines also are responsible for maintaining the mandible state. So you need to give the support to avoid interference on the anterior. That's the mixing of this. You are not understanding. Inclination of the occlusal plane is one thing, and support to protect the joint and avoid impurities is another thing. Okay? Is it clear now? Is it clear? Yes or no? Cool. Do you understand now forever? Don't make this confusion. Otherwise, you have to include incisors, because if you don't have support, you will always touch the anterior. Posterior, control, occlusal plane helps, and incisors must be avoided, and line must be avoided. That's it.
Okay.
Em có một câu hỏi cho thầy. Em thấy là những cái ca mà thầy sâu ra ấy, thì cái kết quả sau khi mà tháo một cài ở khá là nhiều ca, trong những cái ca thầy sâu ra thì một bên hoặc là đa phần là một bên nó vẫn chưa có được lồng múi về khớp cắn hạng 1 mà nó sẽ kết thúc ở cái hạng 3 và nó chưa có cái sự gọi là khóa khớp tự nhiên ấy. Thì em muốn hỏi là em thấy là những cái ca mà thầy nói là thầy thường kết thúc khá là nhanh trong vòng khoảng 1 năm thôi khi mà bệnh nhân còn đang hợp tác tốt. Thì em muốn hỏi là tại sao thầy không có thể là dành thêm vài tháng, nửa năm hoặc 1 năm để có thể chỉnh kéo đến kết thúc để nó là một cái dạng hạng 1 mà thầy lại kết thúc ở đấy luôn. Lý do là do cái thầy dự đoán cái thời gian mà chỉnh được kết quả như vậy nó sẽ mất rất là nhiều thời gian, có thể là 2-3 năm, hay là thầy nghĩ là chỉ cần như vậy thôi là đã đủ rồi và mình có thể tháo được rồi, nghĩa là cái việc chỉnh tiếp là cũng không cần thiết đấy. Và câu hỏi thứ hai là em muốn hỏi là thầy có cái nghiên cứu thống kê nào về cái sự ổn định khớp cắn ở những cái bệnh nhân như thế hay không? Nghĩa là cái mình có theo dõi dài 1 năm, 2 năm, 3 năm ở những cái bệnh nhân đấy về cái sự tái phát hay không?
Dạ biết rồi,
Cảm ơn ạ.
tôi nắm được cái là thầy nói cái nói nhiều quá, hãy dài quá bây giờ tôi cũng không nhớ nổi. And she has a question.
Yes.
And you she noticed from your previous case, one of the case there is not a perfect interdistinction, and you finish in a very quick treatment time. And why don't you spend some more time to make the interdistinction better? But you finish some of the cases, the interdistinction, intercuspation in the posterior, in the buccal segment is not very good. And she would like to know about the stability of such a treatment, and you follow up the case for a long time to see this in good retention.
The question is number one is I try to make a short treatment time. Right?
And you finish in very quick time, but she noticed that the interdistinction is not very perfect.
Okay.
That is interdistinction.
Currently, I try to make more. Long time ago, I tried to make a change of occlusal frame if a posterior part is still opening. But now we change. Yeah, establish nice, even more a nice occlusal establishment. Then finish. Current case. I showed today very old story. 35 years ago, we started that type of treatment. But I will show you more cases. Okay? But anyway, at that time, the big open bite plus 3 case, I don't like to change lower front too much incline this. Then I keep this tooth long axis and change like this. Therefore, upper and lower jaw relations still little plus 3. Therefore, interdigitation sometimes little difficult. But this is not the reason to shortening total treatment time. Why short treatment time? This is okay. Several reasons maybe, but number one is uprighting all the buccal segments. Okay, if you do the uprighting molar, those are 7 upright, those are 6 upright, 5, for this kind of upwriting, each upwriting 2 months, that means total, for example, already 8 months is treatment for the backward segment upwriting. But if you use this Mercury, upwriting at once, all the more upright. This is one reason. And also, in my department, when we started this kind of approach, I recommended to the department of the people, okay, now we should change. Before, well, every time, don't take picture, intraoral photo, don't take every time. But at that time, I strongly recommend every appointment, if patient comes, then something, wire adjustment, ligation, then take picture every time. Then arrange this. This makes shortening total length of treatment time. Because if you take every time photo, then every time patient come watch, oh, my treatment class like this, then now this is a situation. Therefore, we have to do next step, this. Before that, we did many mistakes, same mistakes sometimes. Our goal there, sometimes do this mistake, hopefully, and change to like this, this way to get the final goal.
Muốn nào vào để gọi cháu vào
You have to directly go to final goal. This is not a short. Okay? Don't do same mistake. This is very important. Therefore, diagnosis and treatment planning, this is very important. Otherwise, you have to do same mistake several times. And also, we stop to remove premolar. This is also another reason. We don't have to close the bite or like to, close the extraction space, or the teeth incline this. After closing, uprighting again, this makes space, and close the space. Crazy. Close. Yeah. Yeah. We have several reasons, but the most important part is wearing elastic. This is the most important part. If we can control the patient, nice population, then it's perfect. Final goal. Yeah, this kind of things. Okay. Okay, we should stop. Oh, this one way, I'm hungry. Okay. Okay.
Cảm ơn thầy. Hy vọng với các em buổi ở phía trước, đó là hệ thống CMS và các khối nhọc. Thì em đang liên tưởng đến cái việc điều trị hạng 3. Thì trong cái việc điều trị hạng 3 thì mình có cái tip lâm sàng gì hay là cái giới hạn nào đó để xác định được cái việc điều trị xoay với sau đó, và để có thể là cái phản ứng mà trượt sang người đa trước ở những trường hợp xương loại 3 thì nó không bị tái phát. Và khi mà xương loại dưới luôn luôn có những cái sự hướng dẫn ở CMS như vậy thì để làm sao mà bọn em có được một cái giới hạn để xác định điều trị. Bởi vì em thì được học một số các thầy thì
em vo lại chứ không lại kêu nói dài.
Tức là em
câu hỏi lại cho nó ngộ.
Tức là câu hỏi của em là cái tip lâm sàng và cái giới hạn nào của thầy để khi
vâng như vậy cái đó là Professor, thank you. Yeah. And the mechanism to adapt the mandible forward, to hold the mandible forward is due to thanks to the CMS and the morphology of the premolar, the tooth and the premolar, the bicuspid. This is very good for the class 2 treatment and for the stability of the class 2 treatment. Her question is about the class 3. And so in the class 3, to make it stable, do we need to in this feature, the characteristic, the CMS and the morphology of the premolar help to maintain the mandible backward, because the CMS and the morphology of the premolar help to hold the mandible forward. But in the class 3, we need to do something contrary to that. Can we and how can we know that we can treat the class 3? What limit we of the class 3 can we treat, and how to hold the mandible backward in class
3? Unfortunately, we cannot calculate or estimate how much in class 3 high-end case, how much mandible adapt backward position. This is we cannot estimate. This is a case by case different. Okay, but okay. Today, especially the last part today, I explained about premolar occlusion, premolar guided mandible forward. This is we call P03 guided. Okay? Because this is more important in class 2. Usually, class 3 case, we don't need P03 guided. Because the issues, their mandible is rather forward position. Why P03 guided? But okay, let me finalize this class 2 subject tomorrow. I like to finish. Then we will discuss all this kind of subject. Main question, please. Okay? Yeah. I got you have very much this group very much advanced already. Therefore, I like to change tomorrow's subject. But anyway, tomorrow.
Thank you, Dr. And
Đúng
we
của thầy Thủy nhá.
finish first day and have a
Anh ơi,
picture.
tối nay có nhậu không hay để cho bộ đội về đi tổng kết?
Sato, today. So please stay here. Anh chị em chúng ta dừng lại. thêm một chút để đội ngũ chúng tôi mời đội ngũ của công ty lên trên này để set up ạ. Và để chúng ta sẽ làm một cái ảnh tập thể với thầy, cũng bức ảnh lịch sử kỷ niệm và thầy có mặt ở Việt Nam lần đầu tiên. Và vì thầy không chụp riêng tư cho nên là chúng ta chỉ có chụp thế này thôi. Và rất mong các anh chị để chúng ta mất chút thời gian ở lại. Em chuyển lên chuyển lên đây. Chuyển lên
Em xin tuyển bác sĩ một chút ạ. Trong lúc mình có bác sĩ nào có cái thuốc lạc có chiếc ví cầm tay bên trong có một chiếc chìa khóa xe ô tô không ạ? Thì gặp em nhận lại.
Rồi mất
Em được nhân viên khách sạn báo là có bác sĩ để quên ở phòng ăn trên này ạ.